Hi everyone, welcome to next level ophthalmology. Today we'll be starting a fresh chapter, neuro ophthalmology. I begin this chapter by paying respects to late Dr. Sohan Singh Haire. I consider him the father of neuro ophthalmology. Today's class we will be dealing with the basic anatomy of the optic nerve. The optic nerve extends from the back of the eyeball till the optic chiasm and is around 50 mm in length. The part of the optic nerve that is seen within the eyeball is known as the optic nerve head. So various fibers of the retina converge onto the optic nerve head in the following fashion. The nasal fibers are radially arranged and they represent the temporal field. So as the temporal field is the biggest, these fibers are the thickest. Okay, so they are the first to swell during raised intracranial pressure or papilledema. So the first sign of papilledema is blurring of the nasal margins of the disc. Next we have the temporal fibers which represent the nasal visual field. They arch around the macular fibers. The third is the macular fibers, also known as the PPMB, papillomacular bundle. They run straight from the macula to the temporal aspect of the disc. As they are very thin, they are last to swell during papilledema, but first to be affected in some diseases like toxic amblyopia, Leber's hereditary optic neuropathy and B12 deficiency. So as these fibers enter the temporal aspect of the disc, these patients develop temporal disc pallor. So let's start with the MCQs. Which of the following is true about the nerve fibers in the retina? Arcuate fibers are nasal. Is that true? No, that's false. Then temporal fibers enter the optic disc in a straight manner. Again, that's wrong because temporal fibers arch around the macular fibers. Temporal fibers represent the temporal field. Again, this is wrong because temporal fibers represent the nasal visual field. Macular fibers are the thinnest. Yes, these are macular fibers are the thinnest and they have the most number of ATP. So the answer is D. Let's go to the next question. Which of this is not a cause of temporal disc pallor? So how do you identify temporal and nasal here? Just look at the vessels. These vessels are arching. So arching fibers are temporal and straight fibers are nasal. So this is nasal, this is temporal. If you see, there is some amount of paleness or pallor in the temporal aspect of both. So this is a case of bilateral optic disc pallor. Ischemic optic neuropathy usually is a unilateral disease and causes sectoral disc pallor, usually affecting either the superior or the inferior pole of the disc. Whereas LHON, B12 deficiency and tobacco amblyopia, all three are known to cause temporal pallor of the disc. So here the answer is ischemic optic neuropathy, which does not cause temporal disc pallor. Alright, let's move on to the third question. A 26-year-old man diagnosed with TB lymphadenitis and has been started on 1 gram per day of ethambutol. So here we are supposedly talking about ethambutol toxicity. So ethambutol affects the optic nerve function. So basically they are trying to ask us, how do you look for optic nerve function in this man? So what are the optic nerve function tests? Visual acuity, yes. Color vision, yes. Visual field, yes. So another reaction is pupillary right reaction, which we cannot use to monitor toxicity. So all these three things are used to monitor ethambutol toxicity. The upper limit of ethambutol for causing toxicity is 15 mg per kg per day. So all of the above is the answer here. Which of this is the shortest portion of the optic nerve? As I said, the optic nerve is 50 mm in length. The intraocular part is obviously the shortest because it is just 1 mm in length. Okay, let's see the measurements of the others. The intraorbital is 25 mm, 25 to 30. Remember it's about an inch. Okay, then the intracanalicular is about 1 centimeter, 9 mm to 10 mm, and then the rest is intracranial. It's around 16 mm in length. So the intraocular part that is visible on fundoscopy is around 1 mm in thickness, and it can be further divided into surface nerve fiber layer, prelaminar layer, lamina cribrosa layer and retrolaminar layer. So this is the blood supply. The nerve fibers are supplied by the capillaries arising from the retinal circulation. Okay, from here the retinal vessels enter through the central retinal arteries, branch, form capillaries and come back and supply the nerve fiber layer. The choroidal vessels and short posterior ciliary vessels supply the prelaminar region. Lamina cribrosa is again by dual nerve supply from the posterior ciliary arteries and the circle of Zinhaler. So what is this circle of Zinhaler? It is formed by the pial plexus, retinal artery and branches of the choroidal arteries. So that supplies the next, that is the retrolaminar region. Next, coming to the intraorbital, I said it is around half an inch. It's about an inch, so it is 25 to 30 mm in length. It is sinuous. So what is the use of having a sinuous course? It allows extraocular motility and a small amount of proptosis without affecting the optic nerve function. But the optic nerve is present in a very small cone formed by the 4 recti muscles and their intermuscular septum. So it forms like a closed space. So whenever there is a rise in the pressure in this space, it leads to dysfunction of the optic nerve. Okay, so the causes for these are retrobulbar hemorrhage, thyroid associated orbitopathy. When there is enlargement of extraocular muscles, it can press on the optic nerve. Also, in optic neuritis, there is inflammation of the optic nerve sheath and the muscles are as very close proximity to the optic nerve, and there can be painful extraocular movement. So this is the reason why you get painful extraocular motility just before or during optic neuritis. So next go to the next question. A 44-year-old man meets with a road traffic accident. On examination, he has multiple head injuries. So you are called upon to assess the eye and he is unable to respond. So the patient here is not conscious because he has a low GCS score. Ophthalmic examination reveals severe proptosis, total ophthalmoplegia and hemorrhagic chemosis. So a clinical diagnosis of retrobulbar hemorrhage is made. So they have already given you a clinical clue that there is a hemorrhage in the retrobulbar chamber. So what is the problem here? The problem is the optic nerve lies within the compartment and can get injured if the pressure is very high. So which test will help you understand the optic nerve status? So we have already discussed what are the functions of the optic nerve: visual acuity, color vision, pupillary reflex and visual field. So if you look at the options, all three are right, but you are saying that the patient is unable to respond. So do you think he will be able to do any of the tests here? So the right answer is pupillary reflex, because it is the only objective test. The rest all are subjective tests. So right answer is pupillary reflex. Pupillary reflex is the most important finding that you look for to assess the optic nerve state. So next is the intracanalicular part. So the canal represents the orbital apex where several other structures are in close proximity to the optic nerve. So let's next learn about the orbital apex and I'll teach you. And also remember that the sphenoid and ethmoidal sinuses are very close to this part of the optic nerve. So any infections or inflammation can be a source of infection for retrobulbar neuritis. So this is a picture of the orbital apex, the one within the red box here. So this is the infraorbital fissure. This part is the superior orbital fissure. Alright, and together with the optic canal, this whole box represents the orbital apex. So orbital apex is equal to optic canal plus superior orbital fissure. So what are the nerves that go through the superior orbital fissure? Let's have a mnemonic for this: LFT. Okay, so lacrimal nerve, frontal nerve and the trochlear nerve, LFT. Okay, then there is an intermuscular septum which divides the superior orbital fissure into a superior part and an inferior part. And the inferior part, what does it contain? It contains the abducens nerve, nasociliary nerve and the oculomotor nerve. Can you see here? So ANO and LFT. Then there is the optic canal here which houses the optic nerve and the ophthalmic artery. So What is superior orbital fissure syndrome? Affection of all these nerves gives rise to superior orbital fissure syndrome. So they will have total ophthalmoplegia because optic nerve, trochlear nerve and sixth nerve, abducens nerve. This is responsible for superior oblique. Then the oculomotor nerve is responsible for superior rectus, inferior rectus, medial rectus and inferior oblique, whereas the abducens is responsible for the abducens nerve or the sixth nerve. So in total all the nerves that supply the extraocular muscles are damaged and the person is not able to move his eye. So this is known as total external ophthalmoplegia. So as third nerve is involved, you even get ptosis and loss of pupillary reflex. So as these two are also lost, you get a frozen eye. Okay. Now what about the second nerve? So if the optic canal is also involved along with these, you call it as the orbital apex syndrome. So orbital apex syndrome is features of superior orbital fissure syndrome plus loss of visual acuity. So what constitutes superior orbital fissure syndrome? Total ophthalmoplegia, ptosis, loss of pupillary reflex, and more importantly, because the nasociliary nerve is lost, you get loss of corneal sensations as well. A 14-year-old boy comes with nasopharyngeal carcinoma. Okay, we know that this carcinoma arises from the posterior aspect of the pharynx and then progresses up or down. Presence with left-sided proptosis, total ophthalmoplegia, pupillary dilatation, severe ptosis and loss of corneal sensations. So this person has all the things that I just mentioned to you along with proptosis. So proptosis indicates that there is some tumor that has gone into the orbit and it's pushing the orbital contents forward. So he has all the features of superior orbital fissure syndrome. Let's see what the next line says. His visual acuity is normal. Okay, so now we are sure that the optic nerve is not affected, right? So where do you think the lesion is? It's at the superior orbital fissure syndrome. In orbital apex syndrome, you will get additional of visual acuity loss, and cavernous sinus you get loss of mandibular sensations also, along with other eye also can be affected. You can have abduction deficit of the other eye. Midbrain, you will not have so many cranial nerves being affected at the same time. So the answer here is superior orbital fissure. The next is the intracranial part. The intracranial part lies very close to the olfactory tract. So here there is a clinical implication for this. So what is a Foster-Kennedy syndrome? Okay, Foster-Kennedy syndrome arises due to a tumor of the olfactory region here or a sphenoid wing meningioma that can cause compression of the ipsilateral optic nerve. So when the tumor becomes bigger, it causes raise in the intracranial pressure and causes papilledema of the other eye. So one ipsilateral optic atrophy and contralateral papilledema is known as Foster-Kennedy syndrome. So why is this optic nerve not swelling? Because it is already undergone atrophy and dead axons cannot swell. So what is a pseudo Foster-Kennedy syndrome? So again there is disc edema of one side and the other side there is atrophy. So this is also seen in sequential optic neuropathy, ischemic optic neuropathy. This is classically described for non-ischemic, non-arthritic ischemic optic neuropathy, NAION. Okay, so what is happening is the one eye has already undergone optic atrophy and the other eye is now swollen, disc is edematous because of sequential ischemic optic neuropathy. So the right answer here is anterior ischemic optic neuropathy. So the question is, how will you differentiate between true Foster-Kennedy and pseudo Foster-Kennedy syndrome? Okay, now in pseudo Foster-Kennedy syndrome, the eye with disc edema will have decreased vision and decreased field along with pupillary abnormality, because this is a ischemic optic neuropathy that is affecting the other nerve. Whereas in Foster-Kennedy syndrome, the eye with papilledema will have normal visual acuity. So now let's come to optic nerve function tests. We have already discussed visual acuity, visual field, pupillary light reflex and VEP. Okay, so let's discuss one by one. Visual acuity is affected most of the time, so we cannot say how much of vision may be affected in particular optic neuropathy. It can range from PL negative to 6/6. Patients with perineuritis, in the sense there is only inflammation of the sheath of the optic nerve, they have very good central vision. So what are the cause of perineuritis? Characteristically seen in syphilis, giant cell arteritis and vaginous granulomatosis. The next is color vision or dyschromatopsia. This is always present in all forms of optic nerve dysfunction, and it usually affects the red and green, whereas macular diseases affect the blue-yellow component of the color. Easily it can be tested by these tests here: Farnsworth-Munsell 100 hue test, which is supposed to be the gold standard; Holmgren's wool test, Farnsworth D15 hue discrimination and Nagel's anomalouscope. Can you identify this? These are the plates of the Ishihara's isochromatic charts, and they are actually designed to recognize congenital color blindness, but still they have a role in neuro-ophthalmology. So the next question is the number of hue caps in Farnsworth-Munsell 100 hue test is, okay, it's not as simple as it sounds. It says 100 hues, but it has only 85. So the right answer here is 85. There are 100 hues, 85 hues in the 100 hue test, and it is a misnomer. Okay. Pupillary abnormality, mainly we are worried about the pupillary light reflex. The lesions of the optic nerve always give rise to a efferent pupillary defect, and there is never anisocoria in efferent defects. Whenever there is anisocoria, the defect is in the efferent pathway. We will discuss this in detail in the pupil class. When the lesion is bilaterally symmetrical, you would not expect a relative defect. So you might think there is no pupillary abnormality. A patient with blunt ocular trauma to the right eye is brought to the emergency. There is total hyphema and pupil is not visible. So we are dealing with some kind of pupillary reflex here. In such a situation, if the optic nerve function of the right eye is normal, so we are assuming that the optic nerve function of the right eye is normal. Which of the following is true? So now you have two eyes. Pupil of the left eye can be seen. The pupil of the right eye you cannot see because there is total hyphema. Alright, so you are saying that the optic nerve function is normal. So which of the following is true? Optic nerve function of the right eye cannot be assessed until the hyphema subsides. It is not true. Why? Because the efferent fibers from here go to the brain, and then the efferent fibers come from the brain to both eyes, causing pupillary constriction of the left eye as well. So this statement is wrong. You can still assess the pupillary, the visual function of the right eye. On shining light on the right eye with hyphema, the pupil of the left eye dilates. So you are saying when light is shown here, this pupil is dilating. Is that right? So if the conduction of this eye is good, this should not happen, right? So this statement is wrong. Now on shining light to the right eye with hyphema, the left pupil constricts. So the efferent from here goes to here, comes back to the left and the right eye. But since the right eye pupil is not seen, you see the left eye constricting. So this is right. So probably C is the answer. Now D, on shining light on the left pupil constricts. So left eye, the efferents go to the brain and efferents come to both eyes. So we are not dealing with the efferent of right eye at all. So we are not assessing the efferent function or the optic nerve function of the right eye. Hence this sentence also doesn't make sense. So the answer here would be C. So this phenomena or this clinical method is known as inverse RAPT. So visual field, that is the next optic nerve function test. Optic nerve lesions can cause variety of visual field defects. So these are the typical field defects that are described for each disease. Altitudinal signifies ischemic optic neuropathy. Central and centrocecal field effects are described in optic neuritis, toxic amblyopia and LHON, and enlarged blind spot is described in papilledema. I want all of you to remember these three classical field effects. Coming to the next question. A 55-year-old man has come to you for a general eye check and says he has had an episode of sudden painless decrease in vision. So we have a sudden loss of unilateral visual loss in a slightly elderly gentleman 5 months back. So it's not a new thing. So whatever has happened is an old insult, and after that he says he cannot see the lower half of the visual field. See, you cannot ask for more. They have given you all the possible clues to diagnose. So lower half, so this is an altitudinal scotoma. So where do you get altitudinal scotoma? In ischemic. So we are dealing with an ischemic optic neuropathy that has affected the left eye 5 months back. Okay, so on examination right now you can see that the visual acuity is 6/9 in the upper field, but the patient cannot see below a horizontal line in his field. So we are dealing with an old ischemic optic neuropathy. So what has probably happened to the optic nerve? All the edema will have subsided within 4 to 6 weeks and atrophy would have set in. So once there is loss of axons due to ischemia, again there will be loss of axons leading to decreased visual acuity. So all the optic nerve function, decreased color vision, and then pupillary reflex is not good, and then you might have optic disc pallor. So already they have described the visual field, that's why the visual field is not present in the answers. So all of the following are expected except, so is it dyschromatopsia? Yes, we do expect dyschromatopsia. Then Marcus gun pupil, yes, we do expect Marcus gun pupil. Anisocoria, like I said you, it is expected only in efferent pupillary defects, not afferent. And optic disc pallor is obviously expected. So the answer here is anisocoria. Anisocoria is a pathognomonic sign of efferent pupillary disorders. So now, how does the disc appear? So many a times in optic neuropathies the disc may be normal appearing. So the causes here are retrobulbar neuritis, early stages of traumatic and posterior ischemic optic neuropathy, and pituitary apoplexy. Disc edema may be seen in optic neuritis, the ones which present with papillitis, neuroretinitis, ischemic optic neuropathy, and initial stages of compressive optic neuropathy. The other causes of pale disc are Leber's optic neuropathy, hereditary optic neuropathy, compressive, with time it develops pallor, and then chiasmal compression. So these are a few disorders that present to you with a pale disc. Okay, so the next optic nerve function test is VEP. This is an objective and a quantifiable test, and it is easy and required for documentation in medico legal cases. So whenever you want to document, you have to have a VEP. So the normal VEP has a negative and a positive followed by a negative. Okay, so whatever is negative, the name of the wave starts with N, and whatever is positive, the name of the wave starts with P. So the negative wave is present at 75 milliseconds and we call it as N75, whereas the positive wave, the first positive wave, is present at 100 milliseconds and we call it P100. So we are all worried about this P100. There are two things that we look for it: the amplitude or the height of P100 and the latency. So the time at which the first positive wave appears in VEP is known as the latency. So it should occur within 100 milliseconds. Up to 125 milliseconds we can call it equivocal. So there are some diseases which affect amplitude, there are some diseases which affect latency, and there are diseases which affect both. So in any acute settings, amplitude is always affected, and the recovery from the particular insult depends on the number of axons that have been damaged. So amplitude is low at presentation in optic neuropathies. It may become normal or it may remain the same after a period of time. Alright, but the latency is one thing that once if it is affected, it will not recover. So latency is usually increased in defects affecting the conduction of the optic nerve. So when is the conduction affected? When the myelin is lost. So we are dealing with demyelinating syndromes. So when demyelinating syndromes or inflammatory conditions of the optic nerve can cause demyelination and thus decrease the conduction, causing an increased latency. So increased latency is pathognomonic of demyelinating syndromes. So let's deal with the question here. What is false about VEP? The recording is unaffected by medial opacities. This is true. So whenever there is a dense cataract, whenever there is a high FEMA, when you can't see the retina, when you can't assess the pupillary reaction, you can depend on VEP, and it is an objective test and it is not affected by medial opacity. So this is the wrong answer. We are looking for a false statement here. VEP can help differentiate dissociative loss from malingering. So these both are functional causes of visual loss. Functional in the sense you cannot pinpoint any organic cause here. So dissociative visual loss from malingering, both are somewhere borderline psychogenic causes. Malingering, there is a the patient is willfully doing it for some gain, and dissociative visual loss, the patient is unaware that he is doing this for some particular reason. Okay, so the VEP cannot differentiate between the two causes of functional visual loss. However, it can differentiate between functional and organic causes. So VEP cannot differentiate between dissociative visual loss and malingering. However, it can differentiate between functional and organic causes of visual loss. So probably the answer is B. Let's see the other two options as well. It helps to understand the integrity of the afferent visual pathway. Okay, so this is also true. So this is not the right answer. And the next question is, it helps in assessing visual acuity in young children. Pre-verbals VEP can be used as a tool to assess the visual acuity, and it gives a rough estimate of the visual acuity in these children. So the answer here is B, which is VEP cannot differentiate between dissociative visual loss and malingering. So next question, which of the following is not a characteristic feature of optic neuritis on a VEP? Okay, so we discussed this. A decreased amplitude at the acute attack, yes, this is possible. Increased latency at an acute attack, this is also possible. So decreased amplitude, increased latency. Increased amplitude after recovery from an attack. So I said the amplitude cannot increase, it can come back to normal but it cannot increase from normal. Increased latency after recovery, so the latency might be still affected even after the eye recovers from an acute attack and vision comes back to normal. You might still have an increased latency in these patients with optic neuritis. So when you say optic neuritis, we are probably dealing with MS or multiple sclerosis related optic neuritis. So the answer here is C, increased amplitude after recovery from an acute attack. So the next question now, an elderly man was brought to the OPD with a sudden loss of vision in both eyes of 3 hours duration. So we are dealing with some acute visual loss. He is a hypertensive, diabetic and has hyperlipidemia. So he has this metabolic component which is hinting towards some atherosclerotic or thrombotic phenomenon. Okay. On examination, he has no perception of light in both eyes. So we are dealing with sudden visual loss, bilateral, and with normal pupil and fundus. So the pupils are normal, fundus is normal. In the sense, when pupils are normal, in the presence of a very decreased visual acuity, we should think of lesions behind the lateral geniculate body. Okay, up till lateral geniculate body you can have pupillary disturbances. After that, because the neurons synapse and the second or third order neurons begin from the lateral geniculate body, you will not have optic atrophy as well as pupillary abnormalities in lesions affecting posterior visual pathway. So we are dealing with an acute insult to the posterior visual pathway. Okay, so now this much is clear from this question. Which of the following tests can be used to distinguish between non-organic cause of loss of vision from an organic cause? So here because the pupil is normal, fundus is normal, you might think the patient is malingering. Okay, but until you have had a clear-cut evidence, I'm sorry, you cannot label this patient as functional visual loss. So, electroretinogram, can you do that? ERG gives the topographic representation of how the retinal points are. So, no, this is not the answer. Visual evoked potential, yes, it gives the integrity of the afferent visual pathway. Optical coherence tomography, in the initial stages with 3 hours duration, everything will be normal. The peripapillary RNFL and the macular GCC, all the thickness of the nerves will be normal. Fluorescein angiography will not give you any lead in this case as fundus is already normal. So the answer here is visual evoked potential. Alright, we have come to the end of this class today. See you all next week with the next chapter in neuro-ophthalmology. Thank you.